Thanks very much. So when Ketil called me a few weeks ago and said, what should we talk about, I thought about the common situations I see when treating older people, and it seemed that pneumonia knitted together a number of things that we deal with every day in geriatric medicine. So I'm very pleased to introduce Mr. Edward Tisdale, who is a patient that we're going to talk about today, and at the end of my presentation he's very kindly agreed to answer some questions. Just to say that I have no conflicts of interest, and the objectives, what I'd like to cover is to talk about Mr. Tisdale's illness, the pneumonia and the way it presented to the emergency room some months ago, say a little bit about the history of pneumonia and the epidemiology, causes and complications as they occur in older people, describe delirium as one of the common complications of acute illness in older people, and recognize deconditioning as another very common situation that we see in acute illness in older people. So Mr. Tisdale is 84 years old. He's a very healthy man, and he resides in a residence, a retirement home in Caledonia. Just by way of biography, Mr. Tisdale was telling me on the way down here that when he started work as a long-distance transport driver, that diesel cost 17 cents a gallon. Another biographical note is that Mr. Tisdale delivered the first CAT scanner to McMaster University Medical Center in the 1970s, and also another one at St. Joseph's. So I'm very proud to welcome you here again, sir. So at the beginning of March, he was in his usual state of health, but on the 5th of March, he began to get unwell. He felt weak, he was unsteady, he complained of feeling unsteady, and the staff at the retirement home noticed that he was becoming a little confused. He was taken to the emergency department at Juravinsky Hospital and then admitted. He has a past history of type 2 diabetes, which is well controlled, hypertension, which is well controlled, and he'd had a previous rectal cancer resected some years ago. When he was examined in the emergency room, he was noted to be pale. He seemed to be slow to answer and seemed somewhat confused. He had no fever, his respirations were normal, his blood pressure was slightly elevated, his oxygen saturation was normal. His lungs were almost clear. He had some signs at the right base. His blood work showed that he was mildly anemic. He had a relatively low white blood cell count and a low polymorphonuclear cell count. These are the inflammatory cells, the cells that fight infection in the blood. They were low and not high as we would normally see in a pneumonia. His urea was elevated, indicating some degree of volume depletion or dehydration, and the other tests were normal apart from kidney function, which was mildly impaired. We do a test called the mini-mental state examination. The normal score in an older person is above 27, and most healthy people should score pretty close to 30. And Mr. Tisdale scored only 19 on this instrument, indicating a fair degree of confusion at the time of his illness. His chest X-ray, the one on the right, showed rather subtle changes of right lower lobe pneumonia. They're not obvious changes, they're quite subtle. And this is quite typical of illness in somebody of his age, that these findings are often rather subtle. During his course in hospital, he was diagnosed with pneumonia, which we define as an acute infection of pulmonary parenchyma, or the lung tissue being infected, treated with antibiotics, and made a good recovery. During his stay in hospital, he continued to be confused, although this was fluctuating. Sometimes he was more confused than others, and he was also hallucinating. He was seeing things that weren't there. He remained quite weak for about 10 days, but was then strong enough to return to his retirement home on March the 19th. When I saw him in follow-up last month, he was right back to normal again, and he scored 29 on his mini-mental state examination. Just a word about the history of pneumonia. It's been known since ancient times, and Hippocrates actually described it remarkably accurately about 2,500 years ago. In the old days before antibiotics, it was frequently a mortal illness. And Sir William Osler, who of course is known to all of us, being not only a national treasure, but somebody who actually practiced. His first practice was in Dundas, Ontario, and Sir William was claimed by Canada. He was born here, claimed by the US because he set up the Johns Hopkins Hospital, and he is claimed by England because his parents were English and he spent his final days in Oxford. So we all claim Sir William. And one of the things that he described pneumonia was the captain of the men of death. In other words, a very frequent cause of dying around 1900. And the other description, and hence the name of my talk, was the old man's friend. Because quite frequently in pneumonia, one develops the illness, one slips insidiously into coma and passes away relatively peacefully. So that's the origin of the term, the old man's friend. So life changed very much for pneumonia in the 1930s and 40s with the introduction first of sulfonamides and then with penicillin in 1942. This is a slide which shows the mortality rate among patients with pneumonia, pneumococcal pneumonia, between 1929 and 1935, before the days of antibiotics, and the mortality was approaching 90% in people over the age of 60 at that time. The situation is obviously very different now. The incidence of pneumonia, 5 to 6 per 1,000 per year, more in elderly and more in the winter. It's the 7th most common cause of death in Canada, the 8th in the United States. Risk factors for poor outcome include advanced age, a low body temperature at the time of the illness, volume depletion or dehydration, the presence of confusion or delirium, as we'll talk about, a low white blood cell count, and multiple lobes involved. Commonly caused by bacteria, Streptococcus being a very common cause. Present day, the outcome, it really depends on many factors, but overall the mortality rate from pneumonia is about 5% now. If you require hospitalization, the mortality rate's around 13 or 14%. If you're admitted to the intensive care unit, obviously a much more serious situation, mortality approaches 40%. Most people who are employed will return to their normal state of health within a couple of weeks. In those who are not employed, in other words, older people in general, return to normal in about 24 days, a median number. 87% have residual symptoms at 30 days, and the pneumococcal vaccine is effective at reducing invasive disease. It's debatable whether it actually reduces all-cause mortality. So now let's ask ourselves why he was confused. Well, he has a condition called delirium, or acute confusional state. This is characterized by an acute onset and fluctuating course, disturbance of consciousness, change in cognition, and evidence of an etiology. So in Mr. Tisdale's case, he certainly had the acute onset. He was well before and he was well afterwards. He had a fluctuating course, disturbance of consciousness. He was slightly inattentive. He was hallucinating, and he was really quite muddled up. The cause was pneumonia and other factors. It's extremely common in older people with acute illness. At the admission to hospital, up to 1/4 of older people presenting with an acute illness have a delirium. During hospitalization, about half the individuals will develop delirium. Those in the intensive care unit, it's getting on for 90%, and after surgery in older people, it's as much as 50% also. It carries a high mortality. If you are delirious in hospital, your risk of dying is somewhere between 1/4 and 3/4 of those individuals. And at 1 year, up to 40% of these individuals have passed away. So it's a common and serious illness when we see delirium. Some of the things that it implies is that it delays your discharge from hospital, accounts for about 50% of hospital days in older people. the long-term prognosis is not that great. Even if you recover completely, there's a 20% annual incidence of dementia following an acute delirium. It is, however, potentially preventable, and I will show you in a little while how 30 or 40% of people with delirium can be prevented from having that illness. So many of the things which increase one's risk of developing delirium are exemplified by frail older people. The most common underlying cause for delirium is a pre-existing neurological disease, in particular a dementia, and I should emphasize that Mr. Tisdale definitely does not suffer from a dementia. Age, male, sex, functional dependency, and multiple chronic diseases are other factors which predispose to delirium. And the things which actually precipitate delirium are represented by this rather complicated diagram, and I'll just signal a couple of things. First of all, in his case, he had an infection, he had a pneumonia, and there are many things that happen during an infection. I think Dr. Bodish is going to talk about inflammatory changes in various illnesses, but the markers of inflammation are invariably raised in an acute infection, and that is one of the factors producing delirium. Another one is medications, and there are a huge number of medications which can cause or increase the likelihood of developing delirium in older people, particularly anticholinergic medications, medications that have atropine-like side effects. Here's a few. These are the ones that are, whoops, I pressed the wrong button here. These are the ones that are fairly well known to most physicians. These are ones that are not so well known to many physicians. Drugs like warfarin, for example, very commonly used for treatment of thrombotic disorders. Furosemide, a very commonly used diuretic. Ranitidine, digoxin, prednisolone. These are all drugs that have anticholinergic side effects. And in Mr. Tisdale's case, he was taking a medication for his bladder called tolterodine, which is a potently anticholinergic medication, which I'm sure was one of the other factors that predisposed him to his delirium. I have a checklist that I take to the bedside with me. When somebody is delirious, I want to know what drugs they're on, and if there's anything in their drug profile that may have precipitated their illness. Various endocrine disorders, diabetes in poor control, disturbances of electrolytes such as sodium, calcium, magnesium, changes in thyroid function, all kinds of metabolic disturbances, particularly organ failure. Occasionally you can see delirium after a seizure, a post-ictal state, and this may happen in older people without an observed seizure, and it may last for several days. So that's an unusual course which we occasionally see. In the presence of malignancies or neoplasms, there are various humoral mechanisms that can precipitate delirium, and of course trauma of many kinds, not only a bump on the head causing concussion, but also trauma elsewhere, a hip fracture, for example, or a trauma to somewhere else that may not always be recognized by an individual who suffers from a dementia. Infection, any infection, but particularly serious infections like pneumonia and urinary tract infections being very common. And A is for apoplexy. Apoplexy actually means cerebral hemorrhage, but it just happens to fit the mnemonic, so that's the reason we have apoplexy in there. So I say apoplexy or any vascular event, such as a myocardial infarction, stroke, pulmonary embolism, etc. So that's my little checklist for the things that can precipitate delirium. Now, there are various tools for detecting delirium. One of the best known is the confusion assessment method that has a very high sensitivity and specificity, and this is a very simple tool. You are looking for acute onset fluctuating course and inattention, plus disorganized thinking or decreased level of consciousness. In one of the studies we were doing, the nurse who was collecting the data had these numbered 1, 2, 3, 4, and we remembered it by 1 and 2 plus 3 or 4. So if you can remember the bits and pieces, then that's how you make a diagnosis of delirium. Very high sensitivity and specificity. This tool was developed by Sharon Inouye, who was at Yale at the time, now at Harvard. She is actually going to be presenting at our geriatric day on the 29th, I think it is, of November this month. One of the things that is not commonly known is that delirium does not always get better as soon as the illness is over. And this was a very nice piece of work. It was a systematic review of recovery of delirium done by Martin Cole and Jane McCusker in Montreal. And they looked at a number of different studies and found that it's not uncommon to find people with a delirium that persists for a long time. In fact, by 2 weeks, only about half of individuals with delirium have actually returned to normal. And in fact, by 6 months, 1/4 have still not completely returned to normal. So rather than being an acute illness, an acute situation that goes away in a couple of weeks, it may often persist very much longer than that. So can we prevent it? Well, we can prevent it, and some very nice work again from Sharon Inouye, who did a clinical trial in 1998 where she introduced a number of very simple protocols. There were 6 protocols: orientation, non-pharmacological sleep protocol, early ambulation, hearing protocol, visual, early volume repletion. And these were very straightforward things. So the orientation protocol would involve people in the ward sitting down together and talking about the news, for example. Instead of prescribing a benzodiazepine for people to sleep, then they would have a glass of hot milk and things like back rubs. I mean, we never hear of back rubs. Anyway, whoever last heard of a back rub in hospital? Anyway, they found that this type of thing reduced the incidence of delirium quite substantially. The hearing protocol was making sure that the hearing aid, if worn, was actually in the ear and not sent to the laundry with the sheets, and that visual protocol meant that if glasses were worn, they were actually clean and on the end of the nose and not in the bedside cupboard. And those 6 maneuvers reduced the incidence of delirium at 1 week actually by 40%. And Dr. Inouye would now say, if we see delirium frequently in a hospital, that's bad care. This hospital in Hamilton Health Sciences was actually the first hospital in Canada to introduce the HELP program here, and it's been very successful at the Juravinsky Hospital and now also at Hamilton General. So that's delirium in a nutshell. The next thing that Mr. Tisdale suffered was a great deal of weakness with his illness. And following the illness, it took him a long time to get back to normal. Deconditioning, most simply defined, means the adverse physiological consequences of too much rest. It's a surprise to many people that if you put someone to bed, they lose muscle strength really quite rapidly. Something like 2 to 5% of maximum voluntary contraction is lost each day of complete bed rest. This is work that actually goes back to the 1970s. This was one of the seminal studies looking at 24 entirely healthy young people and putting them to bed and measuring their muscle strength. At the end of 1 week, there was a 23% overall loss of muscle strength. So even in healthy young people, when you rest them completely, they lose muscle strength very rapidly. One of the other things that complicates this situation is that when people are ill, they have excessive amounts of cortisol circulating. And this was a study that looked at putting people to bed for a month, measuring their muscle mass here, and then as a control group, people who are actually given small amounts of cortisol intravenously to simulate the effects of acute illness, and the amount of muscle loss was enormously greater. So just going to bed is bad for you, but going to bed with an illness is really bad for you. Now, on top of that, as we get older, we tend to lose muscle mass. Now, some of that is because we don't exercise regularly. And if you look at people who do exercise regularly, there isn't the same loss of muscle strength and mass that we see in people who don't. It declines by about 1.5% per year in the 6th and 7th decade, and beyond that about 3% per year of loss of muscle mass. That's an average figure, obviously, and does not take into account exercise. If we look at that, this is a, excuse me, whoops, this is a cross-sectional study measuring muscle mass at various ages, and you see there's a downward climb. If you look over a period of time, we reach our maximum muscle strength around the ages of 30, 35, and then we decline gradually and rather more rapidly as we age. Now, one of the implications of this is, can I move this wheelchair into the middle for a moment? This is one of my absolutely favorite diagrams of all time. What it represents is at the age of 20, if you stand up from the sitting position without using your arms, you can do so using perhaps 50% of your maximum voluntary contraction of your hip extensors. So it's really, there's no difficulty for a young person to do that. Even if the young person does it quickly, they're only perhaps using 75% of their maximum voluntary contraction. However, if you take the average 80-year-old person and watch them getting out of a chair, you will find that they will lean forward to get their center of gravity over their feet. They'll push themselves up like this, and they can just about do it. If you put that person to bed for a few days, you may very well drop them below the threshold that they can even do that. So very frequently we see in the hospital older people admitted, and a week later everyone says, you know, why can't they walk again? Well, they can't walk because they have lost their few percent of maximum voluntary contraction on this as a baseline. So it's very easy to convert an older person in hospital from somebody who is just about mobile to somebody who you've now made bedridden. So this is one of the things that we see every day in hospital, and it drives us as geriatricians absolutely round the bend, because there's really no excuse for it. Now, in addition to the muscle strength loss, another aspect of deconditioning is some of the vascular changes. There is a reduction in plasma volume that occurs quite rapidly after putting someone to bed. The reduction in plasma volume is also reflected in cardiac output, and those two things tend to make orthostatic hypotension more common. Orthostatic hypotension is when your blood pressure is good when you're lying down, but when you stand up, your blood pressure drops to the point that you're actually getting dizziness. So just to illustrate this, plasma volume and bed rest, this was a study of simply putting people to bed and then measuring their plasma volume. At the end of 1 week, their plasma volume was dropped by 10%. So instead of having a circulating volume of 5.5 litres, it's down to 5 litres. And that, together with changes in cardiac output, sets you up for syncope and falling. Now, one of the huge advantages of space travel is that it has given us a window into deconditioning, because putting somebody in a weightless environment is actually very similar to putting them to bed. And what do these people have in common? Well, they're both the same age. Senator Glenn, age 78, up in a spacecraft, and this young lady feeling very unwell in a hospital bed. If you actually look at the physiological similarities, they're quite remarkable. So with bed rest, you get increased orthostatic hypotension, balance is affected, coordination and gait is reduced, muscle strength reduced, MVO2 or muscular uptake of oxygen is reduced, and in space flight, exactly the same thing. So this has been a very useful laboratory for studying deconditioning, and it's led to things like realizing that if you keep the guys up in the spacecraft exercising constantly, they don't have the same loss of muscle strength that they do, and their bones don't melt away in the same way that they used to. What about just putting somebody in hospital? Well, this is a study that would never ever be duplicated now because you simply couldn't do it. This is a study from Scandinavia, 78 patients admitted to hospital for investigations. Well, nobody is admitted to hospital for investigations anymore, so there's no way you could ever do this study. What they did do was measure their function, strength, MIPS, 6-minute walk, forced vital capacity, trunk mobility at admission, and again 5 days later. And just being in hospital was enough to change all these things. There was a significant loss of function in all those areas, simply being in hospital. So, we know how you get this way. We know how you become deconditioning. How do you prevent this? How do you treat it? Well, if you do regular resistance exercise, you can overcome that muscle strength loss. However, it takes a lot longer. You lose it at 2 to 5% per day, you regain it about 1% per day. So it will always take you longer to recover from deconditioning than it does to develop it. And that's why we have rehabilitation units who can work on resistance exercise and strengthening and get somebody back well enough to go home even though they have been disabled from deconditioning. This is one of my favorite studies. It was done by Maria Fiataroni, who was a medical student when I worked in Boston. And she subsequently became a professor of physiology, and this was one of her best-known studies. It was done on 90-year-old women in a nursing home. And the study involved an 8-week exercise course, resistance exercise. It was involving that sort of exercise, lifting weights on the foot while seated, presumably not very heavy weights in 90-year-old nursing home ladies, but at the end of 8 weeks, not only was muscle strength increased, not only muscle volume was increased, but the remarkable thing, which is shown on this slide, although you may not be able to see it too well, is that their spontaneous activity improved. So these people who were fairly sedentary started getting up and walking around and going outside and doing things that they hadn't done for a long time. So if you can do that in a 90-year-old lady in a nursing home, in other words, the frailest people in our society, it means you can basically rehabilitate anybody. Resistance training and strength. This was a meta-analysis of 20-odd studies, 28 studies I think, looking at resistance training and muscle strength. And the net result was in every single one of these studies, looking at this, in this case at knee extension, there was an improvement in the strength and overall really quite a significant increase in strength. So we do know that in older people, resistance training will offset that loss of strength that we see in deconditioning. This was a study done by Mark Tarnopolsky here, looking at 6 months of resistance training in 19 older women, 20 older men, with and without supplementation. The supplementation was done with creatine 5 grams per day and conjugated linoleic acid, I think it was 6 grams per day. And after 6 months of resistance exercise 3 times weekly, there was a significant improvement in, this is lean body mass or muscle, increased muscle. This is the exercise and supplement group in men and in women, and this is the body fat reduced in men and women. So the ratio of muscle to fat was changed when you exercised them and supplemented them with creatine and CLA. So, take-home messages. In young people, pneumonia usually presents with fever, cough, shortage of breath. In older people, the illness may present in quite an atypical manner. In other words, Mr. Tisdale, for example, no fever, he wasn't particularly short of breath, He didn't have a cough, he didn't have an elevated white blood count, but he was weak, he was unsteady, and he was confused. This atypical presentation is very common in older people. Next take-home message, delirium often accompanies acute illness in older people. Delirium may be prevented by certain hospital programming, very effectively by the HELP or HELP program. Deconditioning is an extremely common complication of acute illness in the elderly, and resistance exercise will preserve muscle strength and may even prevent deconditioning. We really shouldn't see deconditioning very commonly in hospital. Clearly, the person who spent 3 months in the intensive care unit is not going to be as easy to mobilize as an older person who's just had an acute illness lasting a few days, but that person should not end up deconditioned. So, did I cover the objectives? Mr. Tisdale's illness, the history, epidemiology, causes, treatment and complications of pneumonia in the elderly, delirium as a consequence of acute illness, deconditioning as a preventable problem. May we pause now for questions? Is that the...